Right, we hope you enjoyed that conversation. And with this, we'll be moving on to our panel discussion number 5 for the day. We'll be talking about transforming cashless claims in the payer-provider ecosystem. It's an honor to introduce to you the panelist for this one, Mr. Ambuj Kashyap, co-founder IHX, joining us for this panel discussion. Is Mr. Kashyap in the room? I believe he'll be joining us shortly. We have Mr. Satish, Gidugu, CEO, Medi Assist, joining in. I'll request you all to kindly welcome the gentleman with a round of applause on the stage. We have Dakshna Moorthy, Vice President and Group Revenue Head for Fortis Healthcare, joining us for the conversation as well. Mr. Moorthy, thank you so much for joining in. To moderate the session, we'd like to invite on stage Mr. Ishneh, Kochar, Principal, Boston Consulting Group. And I think that's our panel for panel discussion number 5, transforming cashless claims in the payer-provider ecosystem. We have the stage set. I'll request you gentlemen to take your seats now. I know this is post-lunch and most of you are inclined to take a short nap, but resist that and let's have a round of applause for the panel coming up on the stage.
Well, hello everyone. Thank you for coming in, and I think we have an interesting one on introducing cashless games and how we can really scale this up. I think we have a very well-rounded session, so we'll begin with a few questions, but I think towards the end we may want to just have a few audience questions. Is that fair? All right, perfect. Let me start with you, Satish. I think as we think about cashless claims and the reports that the regulator is really looking forward to have cashless claims as the cornerstone for growth, especially in the payer-provider ecosystem, what do you think are the key challenges that are holding us back? And from your perspective, what will it take to sort of unlock the kind of growth we're looking at?
Thank you. Good afternoon, everyone. Thank you for having us here. I'm Satish. I'm the CEO of Medi Assist. It's nearly over 2 decades since we've started this whole health insurance journey. We still publish a 50-50 of a cashless and reimbursement as a number. And pretty much the only country where, and I think among all of our peers, with the highest out-of-pocket, not just from an out-of-pocket perspective, it's also how much of the coverage, even for the insured members, we are able to provide under insurance covers, right? So if you are looking at over 60% out-of-pocket, and even the 40, and today insurance on an average, we're paying only 70 to 80% of that 40, right? Even though you have the policy. So clearly, I think for us to build belief in the insurance ecosystem, it's critical that one, everybody has access, and especially if you're paying for it as premiums, and that you have some kind of reliability assurance that when I go to this hospital or this provider or this network and this combination of a hospital and the insurer network, I actually get the right outcomes, right? That belief is necessary. Now, clearly, India is a large country, so it's going to take us a little longer effort than a Singapore or somebody else would take in terms of finding all of the hospitals in one shot. Today, I think we are sort of stuck with about, give or take, 20,000 hospitals across the country. We're inching towards the 70% mark by count in some portfolios, which for me is a great improvement over the, let's say, last 5 years, where we've seen it move from 50 to 70%, and especially led mostly by the group insurance today. And if we don't understand how to democratize access, which is how do you build a network that works for different pricing patterns, different affordability ranges, and different outcomes, right? So I think we today have multiple individual segments of solutions. One that is built by private insurer, which is a smaller cohort. One that built by the government for a PMJY and an Ayushman Bharat kind of a cohort. And one tier 2, tier 3 that came in because of COVID, where everybody working from home meant cashless claims moved from tier 1 to tier 2 and tier 3 cities. And lastly, also is influenced by where the insurance penetration today is. I mean, if you looked at 5 years ago, 95% of our claims came from 12 cities. So clearly, it's led by insurance penetration. It's led by, our provider partners to even set up in tier 2 and tier 3. It's led by affordability and finding the right outcomes, and absolute push to not tell a member that you can't do reimbursement, but you eliminate the need to do a reimbursement. Right? I think it's not an easy journey, but hopefully we'll get there sooner than later.
Lovely. I think I'll pick on the cue that it's not an easy journey, and one of the fill-ups that we were expecting on this journey is the entire initiative from ABDM and NHCX, the National Health Claims Exchange. From your perspective, sir, what are the unlocks that you're expecting if this initiative were to catch the necessary momentum, and what would be your requests and inputs to the government to help make this happen?
Sure. Thank you. So my name is Dakshna Moorthy. I represent Fortis Healthcare. Very relevant question. Now, when you talk about this initiative, I think it's a very good initiative from the Government of India. And I think all the hospitals, it'll benefit the entire hospital industry as well as the patients. Now, coming to the challenges, what we see here is the data integration. I think that's the biggest challenge what we see. And also the standardization of the procedures or the packages. So today, every hospital operates in their own standards. I think it is, even if you talk about any network hospital within the group or even outside, there is no synergies in terms of the standardization. So without standardization, if you move for any kind of integration, it is going to be a counterintuitive thing, but we should actually find out solutions. I think the opportunity is in finding solutions, and I feel that like only the hospitals or the providers cannot find solution. It has to be a collective initiative which has to come from various stakeholders. How can we solve this problem? If it is getting implemented, I'm sure the benefit is going to be multifold for entire patients, and also it will actually drive the overall healthcare thing for the India. So I feel this is important that like the data integration, standardization are the key things to drive this faster.
Lovely. I think that makes a lot of sense. I think, Satish, I'm going to go back to you. One of the things is we've been speaking to providers with regards to cashless compensation is if you really zoom out and take the entire view, the process can be lengthy, and it does increase the accounts receivables for providers, right? And I think as we inch closer to initiatives like NHCX, how can we have more standardization in the end-to-end process, which can help providers and payers have it as a win-win, ultimately benefiting the citizens? What are some of the unlocks you see over there?
So there are two parts, right? One is just the process. As a hospital, you know what your protocol is and how much you're most likely end up spending in fixing a patient. You mostly know. I mean, you have enough historical knowledge. As a payer, we mostly know, given a particular policy and the benefits, what is it that we are actually even likely to reimburse out of that cost. It's not that we don't know. Right, today, I think he alluded to it, the whole data exchange and the contracting complexity that we do. Like a simple enough thing, on 5 days, you accumulated, let's say, 1,000 SKUs of bill of materials, but they're sitting and spending 2 hours trying to convert that into the packages that we've negotiated, because the contracting has now taken precedence over simplicity. Right, and similarly, it's not that they don't know the night before discharge that, potentially this is where the bill will end at. And it's not that I can't run a night shift and get everything done, right? And so that the patient can actually get up and walk the next morning. And I think it's not that it's not being done. I mean, between Fortis and Medi specifically, we have a bunch of initiatives that are running to simplify. I'm happy to say that at least 20 to 30 patients a week across Fortis hospitals get up and walk out without waiting for a bill to be generated. But can we take the 20 to 2,000, 20,000 a day? I think that's where the real challenge is. But it's imminently solvable because finally the medical protocols are common, whether you're a payer or a provider.
Got it. Interesting. I think from your point of view also, Ambuj, I think this will be an interesting view. How does IHX see this challenge of driving more standardization in the entire ecosystem? That's the common theme that I think this has come down to.
Hi, thank you for having me. My name is Ambuj. I'm the co-founder of IHX. A very pertinent question, Ishneh. I think it's also a good segue from what Dakshna just said. This standardization of data basically doesn't exist across the Indian ecosystem, right? You have more than 40,000 hospitals which are in the private ecosystem. I think if you total everything, there are more than 60,000 hospitals. Not a single player in this country has more than 500 hospitals as their HIS provider, or the vendor is for the HIS. So when you have that type of complexity, you almost want to think of what does the standardized layer look like in at least one of these places. So you've got 30 odd pairs. You've got much more variability on the hospitals. I think that's where somebody like us actually comes in the middle of this, right? So we operate at about 14,000 hospitals today. We work with Medi, we work with other insurers. This is Aditya Birla, Reliance. And we see a lot of data that comes on from these hospitals in different forms and formats. But before it reaches the insurer or the payer or the TPA for that matter, we actually know what is the type of data that they want. Right? So we are able to then run engines on top of this to standardize it and provide it in a manner that the pair doesn't have to deal with this variability. The pair receives a standardized set, so whatever work that Satish and his team does within Medi Assist, it gets amplified. It doesn't stay slave to the inputs that are coming to it. And then similarly on the hospital side, when they interact with a uniform system, they don't have to interact with 35, 40 different systems just to understand where their collections lie, where their revenue today lies. It becomes that much more easier for a business person to figure out how the business is doing, where are they getting reductions, what are the reasons for those things, and then work backwards from there to ensure it doesn't happen in the future. I think the last part to this is, you've got a patient who's waiting there, right? You've got people in the hospitals who are stressed. You've got people on claims processing floors who are stressed. So in this ecosystem, how do you use digital infrastructure to actually reduce the stress? And at the end of it, as Satish said, right, how does the patient walk home happy? I think that's what you want to use digital infrastructure to finally drive.
Lovely. I think that's very important. So from your perspective in the provider space, Fortis and otherwise, one of the central questions is, do you see in which pockets, whether that's by diseases or whether that's by urban or rural, where do you see cashless claims as being a hit right now? And where do you think you'll find it slightly harder? Is it a cut by urban versus rural or by certain types of procedures? Where do you think we are likely to gain the most traction and how fast?
Yeah, now coming to the cashless claims from Fortis perspective, all our hospitals are under cashless reimbursement. I think that's something we have moved forward. And coming to the challenges, right? Like as a group, we have done it, and we also learned a lot of things when we had this journey moving from a cash to a cashless kind of thing. And putting patients in the center is most critical, right? Like what is good for the patient, and how fast this patient can get treatment, and how fast he can actually go out, go home back. But in this entire journey, there are multiple challenges what the providers are facing today. So one is in terms of the cash flow management. When you talk about cash flow, the hospital industry is a heavily asset management, and a lot of, say, equity comes in terms of cash. So the faster the cash, the better will be for the operations of the hospitals. Now, what happens typically in a cashless is, if you can actually find out a way out, like how the cash can come into the hospital, how the settlement can be faster. And if we can find out a solution that like, okay, someone can get it in a specific time, that like the payment can come in with a minimal documentation from the hospital side, and it can be processed with a certain TAT, then it will actually enable the hospitals to come towards cashless. And if you talk about specific hospitals which is present in a remote location, let's talk about like say 20,000 hospitals across India. And if you want to bring everyone cashless, then it is a huge task. And obviously, everyone have their own challenges. So it's the data. Again, I'm coming back to the data part, and how technology can be used to fasten this entire process so that the patient is getting benefited and the hospital is getting the benefit in terms of cash flows coming in. And also the ALOS is also something which is improved, which will be a win-win situation for most of us. And we welcome the cashless is going to turn around, and we should figure out ways how we can scale this up.
Lovely. So I think from your perspective, figuring out the data standardization and cash flow management. Actually, cash flow management is a theme that does pop up. So Satish, any thoughts on any innovations you're seeing in that space around cash flow management, which you're quite bullish upon?
See, I think it's something that's steadily improving, just the way everything else is improving. So if you look at whether it is Ayushman Bharat or PMJY, there's specific KPIs that the government has set up in tracking provider payments. While that does not touch all of the large hospitals necessarily, but it's an important KPI, and it's sort of built into how we run the government-sponsored schemes today, where one of the key KPIs that we are measured on is the speed of payment to the hospital. But the good thing is, very interestingly, all the mass and public health schemes are 100% cashless. It's only our private insurance which has reimbursement today, right? And everything is fixed, the procedures are fixed, the hospital knows what to ask for, the provider and the payer knows exactly what to look for, the protocols are agreed upon. I think we need to get to that first, the standardization, so that there is no post-discharge relook at the case and the commitment that we make. So one of the important things, I think, I can only give you Medi Assist example, is an internal metric that we've set up is, if I promise to pay 100, is this 100 when it is actually paid? Because that variance itself is a secondary problem. One is a delay. Second is the difference between what you promised to pay versus what you paid. From what used to be single digits, I know that at Medi Assist over 16,000 crores, it is 0.5%. It's not zero. But we managed to bring it to 0.5% because we take pride in making that commitment at the time of discharge. Today, we're about 90% of the claims, we are able to get that done real quick. There's a 10% as an industry that we haven't yet solved between insurance and the provider. It's not a 100% problem. There's a 90 that works without any intervention, without any issues. There's a 10 that causes most of the anxiety. But on the flip side, if we can get to 100% cashless, a lot of us today spend a lot of money on investigating frauds, looking for bad cases. We spend truckloads of money on verifying reimbursements. If the whole industry can move to cashless, it itself will unlock enough money within the existing spends. Then there is no reason why industry cannot move to better payment cycles, right? Using that efficiency, you don't need extra money for it.
Yeah, I'm going to hold on to that 90% number. I had some questions there, but Ambuj, anything specific on that? Again, I think that's a recurrent theme we keep hearing about, managing cash flows better. Any thoughts on what unlocks can be there?
So I think part of the problem is that when you have a very manual process, which is the process when you don't have data to work with, there will be non-standardized adjudications which will happen, right? So there will be discretion at play. There might not be enough data to work with. And at that point of time, it is difficult to put a ring fence around it to say this is how well we're going to adjudicate, right? Satish, to his credit, has put together, he was a CTO before this, and then he became a CEO, so he realizes the importance of data. Yeah. But if you're able to standardize some of this infrastructure such that this information which is needed at the right place, at the right time. So for example, during discharge, an average bill that gets generated during discharge is 6 to 8 pages. Might be longer, might be slightly shorter, 160 line items on that, right? So if you are going to miss out line items at that point during the adjudication process as a pair because you weren't able to tabulate it properly, maybe it was a non-medical expense at that point of time, you weren't able to mark it properly, and then later at settlement you realize that no, this should have been marked as a non-medical expense, it will lead to a disallowance, or that's one of the cases, right? Sure. So those are things where we think that having the standardized data, allowing people to do the same thing over and over again. So for example, when we work with hospitals, we've now got engines that are able to extract all of this data. So think of this bill, right? We're able to take that data out, categorize it, and then present it to the adjudicator to say, look, these were the different categories that you got here. So you don't have to do this manual work of going through and looking through each of these line items to figure out what was happening. One, it improves the turnaround times, but two, it also gives you a repository that you can go back and look at to see what might have happened. Yeah. Right? So now you are able to have much more transparency, and at some point of time, we would also like to tell the hospitals the same thing. That look, you've prepared a bill, this is what we've generally seen, so you at least have an idea on what might be a non-payable so that you know what's coming your way. Or you're not able to, you're not going to tell the patient at the last moment that, look, I asked you for 20,000, but it looks like you might have to pay another 15,000 before you leave. Yeah. So those types of things go out of the system when you have access to data and when you have access to it in a standardized format.
Lovely. I'm actually going to ask this question jointly to you both. Anywhere cashless is a theme that we keep hearing quite a lot. I think there have been few which have sort of also, ICICI has come up with that point of view on having anywhere cashless. Your thoughts on what it will take to succeed for the larger audience to sort of borrow this. Satish, I'm also going to borrow that 90% number that you have. You seem to have created a larger network, having a higher amount of cashless settlements. If we have to move to the goal of being anywhere cashless, I think your thoughts on what it takes.
Yeah, so I would like to actually answer this question putting patient in the front.
Sure.
Okay, because they are the consumers, and obviously when the consumer is stepping to the hospital, they come with an expectation that like everything is going to be cashless. And obviously there's a lot of catch on the policy, right? Like when a consumer is buying a policy, there are a lot of terms and conditions which is there. And obviously today's scenario, all the consumers, all the patient doesn't know exactly what is the policy covers. So to just move towards the cashless and also how we can actually increase that overall better experience for the patients, it's important that the awareness, what we create to the patient about the insurance policy is extremely critical. I think today's situation, when I go and invest in any stock market, I think I'm getting all information saying that, okay, this is what is covered, this is not covered, and this is a risk, whatever. I think as an investor, I'm pretty much aware that what I'm taking. From a health insurance perspective, when a patient is going and getting a health insurance policy, I'm not sure whether he is completely aware about the terms and conditions. Even in cashless, whether everything is covered, is there something which is coming as a non-medical expenses is not covered, and all these things, the transparency is something which is very critical. And obviously, it's about creating more awareness. So once we create more awareness on the product, what we are selling from the insurance companies, then obviously that experience will improve. And the hospitals, at the end, we are service providers, right? When the patient is stepping into the hospital, obviously the experience what the patient gets inside the hospital is getting registered in his mind. And obviously, many times the patient doesn't recollect that what was the conversation when he bought the policy. So I think that's the thin line. I think obviously we have to find a solution with everyone coming together and see like how can we create awareness of the health product and what are the services which is covered, not covered in the health insurance. That will actually enhance. Number two, in terms of the cashless claims, as I told you earlier, I think it's a welcome move. We should actually move towards the cashless so that there is a lot of transparency. I think first thing is like a lot of transparency. This will also bring in a lot of compliance from a hospital perspective, and it makes the job much easier for the provider. It makes the job much easier for the payer as well. Because more or less it is getting standardized, and from the hospital side, we also know how to manage the cost. If this is going to be reimbursed, this is pretty much there, then obviously it makes the experience better for the patient and also for the provider. That's what I would put across. Thank you.
So just to add that, so I think there are 2-3 ingredients that are needed. One is trust. See, today you go to a pharmacy and you buy a particular medicine. No matter which pharmacy you go to, you buy the medicine at the same price. And you know it's the same ingredients, they don't change unless, of course, something fake sort of made its way through. So there are things, and it's regulated by the government. And when you send somebody to a pharmacy and then they call you and then say they're saying it's 100 rupees, you're not going to sit there and negotiate, right? You trust that it is 100 and you pay the 100. So what more process do we need to pay for something that's already standard, right? You can now extend that to a hospital, you can extend that to a knee replacement. The implants are price capped by the NPPA. Let's say it's 36,000 or 32,000, whatever be the number. If the hospital is saying, I'm charging you 32,000, what else are you going to really check? There's really nothing to check, right? So, but we've not established the trust today. The trust is coming through contracting. The trust is not implicitly being provided by a third party, like in a pharmacy where there is a licensing that assures that the pharmacy is genuine, right? With hospitals today, we are trying to build trust one-on-one, right? So that's one challenge. So for each hospital, we're looking at the same procedure, same bill from a very different lens, which is an unfortunate overhead that we end up creating at the processing. The second is the standardization, right? While Ambuj alluded to it, imagine each bill is a line items, right? There are unique line items, the SKUs. With a limited cashless network that we have, I have 1.8 crore unique SKUs in my system across 13,000 hospitals that are giving me discharges. And the 1.8 crore SKUs have to be understood, paid for, and you have to determine, you still have to let the patient out in 1 hour, right, or less. And hence, the third, it can't happen because it's a humongous effort. The government does not have a standard SKU database for medical items. Pharmacy, there are no pharmacy SKUs that we can use. And then the only solution then is to simplify the product and the promise of the product, where at least we're able to have a conversation saying, hey, Dakshna, can we say, when you do an open heart surgery, if a patient is there and no other complications, 5 days with 3 days ICU, let's agree that it will not cost, whatever happens, 2.5 lakhs, right? Let's assume that, right? Yes, and on some you lose and some you gain. Yeah. But if you can't have that simplicity in the way you talk to the provider, and you can't build that simplicity back to the product, where you're willing to pay your member, saying, I will pay you 2.5 lakhs for an open heart surgery, irrespective of the hospital, as long as the hospital is a known hospital, it's very hard to solve that problem only as a data problem, right? Finally, the intent and the simplicity has to come back in.
Sure, sure, please.
I think from a standardization from the cost perspective also, so I think every provider works in a different set of environment. I think one thing, it's also important for the payers and also the TPAs and everyone to understand what are the complexities involved in the hospital provider space. Because once they understand the real problem, then possibly it's easy for us to actually find a solution. So many times what happens is like understanding the problem itself is a gap. Possibly the providers doesn't understand the insurance part very well, and possibly the payers don't understand the provider's problem. So it's important to see like what are the different elements, even in any particular treatment or any particular modality, what are the things which comes in. I'm just giving an example of, say, new technology in terms of robotics. So robotics is now coming in as a big standard of care, right? I think most of the insurance companies are not covering robotics as a treatment method, most of the companies. So when there is a push towards giving better outcome in terms of clinical patient outcomes, and technology is integral part of it. So I think from that perspective, if the insurance companies can understand what is that like the patient is going to get benefit, and then design the policies or maybe the things, that will actually help us to just move forward in a very constructive way. Just want to give a thought in terms of an example. Yeah, thank you.
You want to add something to that, Ambuj?
I think when I hear the two of them talk, I think of myself that I'm a two-sided network between the two of them, dealing with the problems on this side and that side. I mean, I can't add more to what Satish said in terms of standardization, right? But I think that's where some of the initiatives that will happen between building payment integrity into the system, right? Which is having the visibility on what is it that is getting charged in a particular case. So I'll give an example. We've been working with an insurer on this, right? So we've been thinking of what do standard treatment guidelines look like. And standard treatment guidelines are not clinical guidelines to tell a doctor what you can prescribe versus what you cannot prescribe. But do you at least have the ability that if a person walked in with a particular disease, there was a set of documents that would be needed for this case to get adjudicated? Yeah. Would there be a set of lab reports that you would expect that for this particular diagnosis, there should be this lab report that exists with it, right? Those types of things, I think, start solving the problem to an extent where then you can standardize some of these SQs, for example, that Satish talked about, right? Because then it's easier once you have that database to actually correlate. So you don't go and tell a doctor, why did you prescribe this? But you have, from an information completeness perspective, at least ensured that whatever the hospital is sending is complete, and it can be used in a standardized manner by the adjudicator, so to speak, at the insurer or the TPA. So that I think that will go some way in actually building trust within this ecosystem, that nobody's actually got the wrong thing there, right? There is transparency, and built on that transparency is this trust that's going to come between the payer and the provider. And we'll hopefully be in the middle of all of this.
Excellent, excellent.
So I'm sort of somewhere in between the two. See, each of us in this room today, we don't go to the same coffee shops, we don't drink the same, we don't eat the same, we don't buy the same clothes, we don't drive the same. Yet we all somewhere expect that if all of us, God forbid, had typhoid tomorrow morning and checked into Fortis, and all of us spent 3 days each, we should all have the same bill, which sometimes unfortunately does not work, because every human body and every treatment is very different from everybody else's, right? So I think, but having said that, there is an 80-20 rule in everything, right? I'm sure that even from your perspective, there's an 80% that follows a predictable protocol and a pattern. And if you overlay that with what Ambuj is saying, what is the minimum basic things that we need as standard, we will at least solve the 80%. I don't think we can We today have the ability to solve the 100, but because we're not solving 100, we're not solving even the 80 today. There's really no reason why he wouldn't know 80% of the patients what their bill will be when they leave based on how unhealthy the person is on the day of admission. He would know mostly. And when I talked about trust, he should be able to tell me, hey Satish, for this patient, I expect this person to check out at between 70 to 80,000. And I should be able to trust and then say, listen, between 70 and 80, this policy will pay outside 20%, co-pay 80% of that. Please don't come back and ask me, we will deal with it later. It's enabling that conversation. Using some basic heuristics and technology is what will at least get us in the 80% mark. Otherwise, it's very hard. Right? We can keep discussing at each transaction level.
Go ahead if you wanted to add. This is getting interesting. Satish, I was also reflecting on one mark. You said that the government schemes are all coming under the unified portal to get into the cashless. From your perspective, how prepared is the private sector in participation in things like NHCX and some of the mega themes that are playing around? Where is your assessment of the overall private sector here?
There is no question of preparedness. I think we are more prepared than everybody else. It's the product definition and it's the willingness to enforce. Remember in the government sector, you are dealing with the bottom 50 crores of the population who can't afford healthcare. So they're not sitting there and making choices, unfortunately. They're just making sure that they're not going bankrupt in getting basic healthcare. And the government has created a scheme and enforced a set of rules. Yeah. Today, one, we are not able to enforce rules in private insurance, neither as providers nor as payers. Nor do we have the basic, let's say, the contract enforcement infrastructure. For example, imagine I have an insurer, I'm not an insurer, all disclaimers, and he generates a bill for 100 rupees. Why am I not paying him 100 and recovering the 20 from, say, Ambuj tomorrow morning on my own? And that's what happens everywhere outside India. Because if he doesn't pay up the 20, it will reflect in his credit report, it will reflect in his credit scores. You can actually enforce a contract today. Today, no hospital, and forgive me for saying generalization, has the trust that when the patient walks out, they'll ever be able to recover that money. So today we make the patient wait until both of us come to an agreement. So at some point, that willingness has to be there in all the parties to do something different and something in a different manner.
Just want to add up one thing. I think we are working with Medi also, with most of the insurance companies as well, to work on giving a better experience for the patient on discharge. Yes. Because the biggest challenge once it comes on cashless patients is on discharge, and they spend quite amount of time in the billing desk to actually get it cleared. So that is one of the problems. I think one, again, if we can build the trust between both the organizations, then we can able to solve this problem. And I can give some examples. I think we are working with Medi Assist in multiple locations for our provider network to give D-1 discharge. That means the patient gets discharged one day before and all the formalities will get completed one day before when he gets steps of the hospital. So that's again a move towards giving a better patient experience. How cashless claims should not be actually only on paper. It should actually give that kind of benefit and also the experience to the patient, both from the provider as well as from the payer front. So that's where it is, yeah.
That'd be one fantastic thing to happen. We're almost at time. I just want to pause and see if there are questions from the audience for the panel here. Sure. You may have to speak a little louder from there.
Yeah.
Yeah.
Without the major insurance even reaching them, is that a possibility, and has anyone done anything?
I think I'm fairly incompetent to answer that question as a TPA. What's happening on the ground with the Ayushman Bharat, which is formally called Pradhan Mantri Jan Arogya Yojana, is I think is a very solid system. Today The ambiguity of who is covered is removed. It's all based on census data. Everything is linked to Aadhaar. The list of hospitals is known. List of procedures is known. List of money, pricing is known. And today, almost all the states, with the exceptions of few, have adopted the same template. So in fact, if you are if you are a domicile of one state and you end up in some other state, you're still able to get treatment under the same, same cover. Even that happens today. And most states have been able to fold their existing health insurance schemes that are covering somebody else and either made it a pre-PMJY or a post-PMJY cover, and collectively they are able to pool all of those covers together. And I think it is a success story. I mean, that is the closest, and I think it's probably one of the best run programs.
Anyone else? Or Ambuj, anything anything you want to add? All right.
Please don't fall sick. If you do, please use cashless. Right? Yeah. And that's the only thing. Thank you so much.
I think we have a question there, sir, on that side. Yeah?
Yes, please, go ahead.
This is regarding the low penetration of PMJY in the private sector. So, Mr. Daksh, any thoughts on why the penetration of PMJY is very low today?
So yes, acceptance is low, penetration is low, but I think all the private service providers are working on it. I think there is a specific task which has been taken from the hospital side also to see like how can we actually participate in this, because it is there are multiple factors on this, right? Like in terms of how the package comes in and how we can actually fit in this package in the overall hospital costing is one thing which we are working out. And also the care is something which cannot be differentiated. It has to be a same care what we are giving it. So there are challenges which are there, and obviously the providers are working to get closer in terms of the participation. So you will see that going up, but maybe Satish, you want to add?
I just want to add one data point. It is not that there is no private sector participating in it. In the schemes that we run, anywhere from 20 to 40% of the outgo does go to the private hospitals, except that the government is mindful of the ability to provide care at a certain cost. And there is a natural preference to use the government-owned teaching hospitals and the government hospitals in the existing network. But the private hospitals play a significant role in multiple states. It may not be universally true across the country, but there's a significant participation.
And just want to add, if you see that like most of the hospitals are already participating in the CGHS and ECHS schemes. It is also government schemes, right? I think even if you talk about the private sectors, almost many private, even Fortis I can talk about. I think Fortis, most of the hospitals are actually participating on ECHS and CHS schemes. So definitely there is an intent in terms of going towards that, and we are working on it. And you will see that moving up as well in different schemes when it comes in.
I believe we have time for one more question. Any other questions from the room? All right. Thank you so much, gentlemen. I'll let you take a picture together. Mr. Kashyap, thank you so much. Mr. Gidugu, thank you. Mr. Moorthy, and of course, Mr. Kochar for joining us at the Digital Health Summit 2023. Now's the right time for you all to put your hands together if you enjoyed that conversation, yes?